So a 65-year-old woman slips and falls on the floor of the toilet, cannot move the hip. There's pain, swelling, deformity and loss of function around the hip. And the loss of function means that movements are very painful, cannot raise the limb in air, cannot walk or stand. When you stand, either you stand on the left or you stand on the right or you stand on both, and cannot sit. You sit on a chair, you sit cross-legged and you squat. So when any of these functions is lost, it is supposed to be around the hip. So what do you think has happened to this woman? What is your diagnosis? Anybody? So one is fracture neck of femur. Any differential diagnosis? Any other diagnosis? Any other possibility? Trochenteric fracture. All right. So you can have a fracture of the neck of femur or the fracture of the trochanteric region. The difference is that since the capsule is attached to the intertrochanteric line, the capsule in neck of femur is attached to the distal fragment. Therefore, it will not allow too much of deformity or shortening. Whereas in a trochanteric fracture, the capsule is attached to the proximal fragment. Therefore, the distal fragment is free to rotate or displace as much as it wants. So there is more deformity in a trochanteric fracture than in fracture neck of femur. More shortening in a trochanteric fracture than in a fracture neck of femur. And the third difference is that there is tenderness in the Scarpa's triangle in fracture neck of femur and tenderness on the trochanter in trochanteric fractures. The fourth difference is that if you see in an old case, a fractured trochanter will malunite. This fracture will malunite. That is the complication of trochanteric fractures. But a fractured neck femur, the complications are non-union, avascular necrosis. You see, neck of femur, non-union, avascular necrosis, osteoarthritis and osteoporosis. So these are the complications of neck of femur and this is the complication of a trochanteric fracture. Okay. Now, why do you say it is a fractured neck of femur or trochanteric fracture? If they ask you that question, you say that there is a flexion, adduction, external rotation deformity with true shortening. So, if this is the finding on examination, these are the two possibilities. But supposing I say that instead of external rotation, there is a flexion, adduction, internal rotation deformity. What is your diagnosis? What will be your diagnosis? Your diagnosis will become posterior dislocation of hip. If I say that there is a flexion, abduction, external rotation deformity, your diagnosis will become anterior dislocation of hip. If I say that the Morris's bitrochanteric test is positive, and you can feel the head in perrectal or vaginal examination, feel the head in the pelvis. then it is a central fracture dislocation hip. So that is the differential diagnosis of fracture neck of femur. And Morris's bitrochanteric test, I am telling you that if this head moves inside, ruptures the acetabulum floor and moves inside, then the distance from the pubis of this trochanter will become less as compared to the opposite side, because the head has gone inside the acetabulum. So that is the Morris's bitrochanteric test, and of course, if you do a per rectal or per vaginal examination, you will be able to feel the head in the pelvis. So that is the clinical differential diagnosis of injuries around hip. Fracture neck of femur, trochanteric fracture, posterior dislocation of hip, anterior dislocation of hip, central dislocation of hip. Okay? Now, after this, what will you do? You will put the patient on a long distance splint. You will put the patient nil orally, because on arrival in hospital she may need anesthesia. In the hospital you will give a below knee balanced traction. And you will take an X-ray of the pelvis with both hips in identical position. Alright, as much identical position as possible. So we will show you this X-ray if the net can be switched on. No internet. So sorry, that means you can't see that X-ray. We will draw it for you. So in fracture neck of femur, if this is the head, this is the neck, this is the trochanteric region, and this is the lesser trochanter, and here you have the picture of the acetabulum. Here is the pubic symphysis. Then if you trace this line, the superior border of the acetabulum, and go on to the neck of femur, this line is called as Shenton's line. And you will find that there is a break in the Shenton's line. And this break may extend to the superior border. So break in Shenton's line indicates a fracture neck of femur. Now, how do you classify this fracture radiologically? The fracture can be subcapital, transcervical or basal. So first is the anatomic classification. When the fracture can be subcapital, transcervical or basal. The second classification is dependent on what is called as Powell's angle. You see, I will draw it for you. Supposing this is the head of the femur, this is the neck, this is the trochanter, and here is the acetabulum of this side and here is the acetabulum of that side, and you draw a line joining the two acetabular ribs. So you join a line joining the two acetabular rims. This is the head of the femur, and here is the fracture. Then you join the fracture line to this. Now this angle between the horizontal line joining the two acetabulums and the fracture line is called as Powell's angle. Is called as Powell's angle. Now supposing this Powell's angle is vertical, then the muscle forces acting like this. Here will be the trochanter and here is your fracture which is vertical. So the muscle forces will act like this and the weight of the body will act like this. So this is the weight, this is the muscle force. And there will be a shearing stress on this fracture. Shearing means that this will slip. So there will be a shearing stress on the fracture. If the Powell angle is greater than 70 degrees. The second situation is that if this is the trochanter, this is the head, lesser trochanter, and supposing the fracture is horizontal, that means this is the Powell angle. This is the Powell angle. It is less than 30. Then the muscle force and the weight will compress the fracture. You want compression or shearing? You want compression. So a horizontal fracture is more likely to unite than a vertical fracture. That's the importance of Powell's angle. Third classification is called as Gardner's classification. The Gardner's classification means incomplete fracture. Incomplete, that means only the Shenton's line broken. Then it says complete fracture. I'll say this is complete fracture. But this complete can be either undisplaced, partially displaced, or completely displaced. So, according to the Gardner's classification, you can have an incomplete fracture, a complete undisplaced fracture, a complete partially displaced fracture, and a completely displaced fracture. Now, I will tell you what is the difference between partially and completely displaced fracture. If this fracture is partially displaced, that means it is hinging, these two fragments are hinging on each other. So if there is a deformity of this, that will rotate the head in this direction. And therefore, the trabecular pattern of the head and the trabecular pattern of the acetabulum will not match, because the head is rotated in the acetabulum. So that partially displaced fracture means that trabeculae of head and acetabulum not aligned. And if it is completely displaced, the head will return to its original position, and therefore this trabeculae of the head and the acetabulum will align. So when they ask you whether it is a Gardner's type 4 or Gardner's type 3, you can say whatever it is, and you can say by the X-ray that if the trabeculae of the acetabulum and the head is aligned, it is type 4, a completely different. Naturally, completely displaced fractures will be much more difficult to reduce than partially displaced axis. So the first question is there a fracture? The answer is, if there is a break in the Shenton's arch, there is a fracture. The second question is, where is the fracture? And you see the lesions, the fracture can be in subcapital, transcervical or basal anatomical place. So if the fracture is vertical, that means the Powell's angle is 70, then the weight and the muscle forces pulling the trochanter upwards will cause a shearing stress on the fracture, and the fracture will not unite. However, if the fracture is horizontal, that means the Powell's angle is 30 degrees or less, then the weight and the muscle forces will produce a compression stress, and these fractures are more likely to unite. The third is the Gordon's classification. An incomplete fracture, a complete fracture, undisplaced, a complete fracture partially displaced, and a complete fracture completely displaced. In the partially displaced fracture, the acetabular and the head trabeculae will not align because the head is rotated in the acetabulum. Lastly, in an old case, you must look for non-union of the fracture, the avascular necrosis of the head, the osteoarthritis of the hip, and osteoporosis. So on X-ray of the pelvis, you answer whether there is a fracture by break in Shenton's line, what is the site of the fracture, the subcapital, the transcervical, the basal, what is the Powell's angle, whether it is vertical or horizontal, and the Gordon's classification, incomplete, complete, partially displaced or completely displaced, and finally, if there is an old case, whether there is non-union, avascular necrosis, osteoarthritis or osteoporosis. Now you have this patient, you have done an X-ray, and on radiologically you have confirmed your diagnosis. Now what do? You put the patient on BK balance skin traction, then you have taken the X-ray, you do intake output charting, because what happens? These are old patients. They think that they'll have to go to toilet, and to avoid the toilet they stop drinking and eating, and therefore they go into pre-renal uremia. So the next thing you must do is nutrition and nursing, because if you don't do nursing they will develop bed sores. Okay? Then you must investigate for anesthesia and surgery. And what I used to do, I have mugged up the pre-operative investigations. So I say to assess the general condition of patient, I will do hemoglobin, TLC, DLC, ESR, GBP, BT, CT, blood urea, blood sugar, urine and stool examination. Now instead of the BT, CT, you can do INR or coagulation time. Then I want to assess the cardiovascular and respiratory status. And to assess the cardiovascular and respiratory status, I will do an electrocardiogram, I will do an echo, and I will at least do an X-ray of the chest, PIMS. Then I must know the rehab potential. So I must know something about the vision, the mouth opening, and the weight of the patient, and general mental status. Because better the rehab potential, more chances are that the patient will respond to your physiotherapy. Now, fracture neck of femur usually is treated by surgery, and therefore there is choice of surgery. What is the choice of surgery? You put the patient in the OT, give general anesthesia or spinal anesthesia, part prepare and drape. Now, in young people below 65 years of age, below 65 years and above 65 years, your approach is different. Below 65 years, if you can reduce the fracture, you fix it. You reduce the fracture and you fix it. And how do you fix? You can fix by cannulated cancellous screws. Or you can fix by dynamic hip screw, DHS. Now, if the fracture is irreducible, then you can open reduce and fix. But whenever you open reduce, you always add bone graft. Now, the bone graft is based on, it is a pedicle bone graft. Why pedicle? Because it is based on muscle insertion. So you take the iliac tuberosity, which is based on the tensor fasciae lata, or you take the quadrate tubercle, which is based on the quadratus femoris muscle. And this operation is called as osteosynthesis. Another alternative for irreducible fracture is that here is the head, here is the trochanter, and here was your fracture with a lot of Powell angle, 70-degree Powell angle. Now, if you do an osteotomy here and you open your shaft like this, then the muscle force will become like this, and the fracture force weight will become like this, and therefore what was causing a shearing stress has now started causing a compression stress. So this osteotomy is called a subtrochanteric valgus osteotomy to reduce the Powell angle. All right. So, if it is reducible, cannulated cancellous screw or DHS. If it is not reducible, open reduce and osteosynthesis, and otherwise an alternative alternative is subtrochanteric valgus osteotomy to reduce the Powell angle. Supposing you do a 30-degree valgus osteotomy, the 70-degree Powell angle will now become 40 degree. Alright? Then above 65 years of age. Above 65 years of age, you want the person to quickly start walking. And therefore, if only the head is involved, you do a hemi replacement arthroplasty. That means you replace only the head. If there is osteoarthritis, that means head plus acetabulum involved, then you do a total hip replacement. And if the person is poor, can't afford a total hip, needs ground level activity, that means needs to squat, to sit cross-legged, doesn't have a toilet at home, has to go in the field for toilet, needs squatting. So if the patient is poor or needs ground level activity or is a high risk, then you simply excise the head. That is called as excisional arthroplasty. What will happen with the excision of the head? There will be shortening. There will be a Trendelenburg gait. Alright. But there will be full movement and no pain. So, if this is the pelvis, it is a basin-shaped cavity, and I have excised the head. So this is the trochanter. If I make the proximal fragment parallel to the false pelvis, and if I make the distal fragment parallel to the true pelvis, then when I try to adduct, this will prevent adduction. This will prevent adduction here. If I try to abduct, this will prevent abduction. So since now the shape of the upper end of the femur is the same as the shape of the pelvis, therefore this will neither prevent adduction or abduction, and it will also not prevent upward migration. So this is pelvic support osteotomy, which takes care of the Trendelenburg gait and shortening. And when you combine pelvic support osteotomy with excisional arthroplasty, it is called as Milch-Bachelor's operation. Another reason why you cannot do a total hip replacement, poor ground level activity or too much of osteoporosis. If there is osteoporosis, then you will not be able, it will not be able to sustain the implant. So, I have covered for you the fracture neck of femur. In short revision, it is a 65-year-old lady slips and falls on the floor of the toilet. To prevent that fall, what could you have done? Don't wash clothes on the floor of the toilet. And don't use smooth tiles. And have places where the old people can grab the walls and take support and not fall. Alright? So she fell, she cannot move the hip, cries with pain when you try to move her, has pain, swelling, deformity, loss of function around hip. I have defined what loss of function is. You examine the patient, there is a flexion, adduction, external rotation deformity with true shortening above the trochanter. Now the true shortening above the trochanter is measured by Bryant's triangle, Shoemaker's line, Nelaton's line, Shinnie's parallelogram. 4 ways of saying that the trochanter has shifted up. Differential diagnosis, trochanteric fracture. How would you distinguish? In neck of femur, the tenderness is in the Scarpa's triangle, and since it is an intracapsular fracture, adduction, external rotation and shortening is not too much marked. In trochanteric fracture, these deformities are marked. There is thickening and tenderness of the trochanter. Alright. Trochanteric fracture will malunite. Fracture neck femur will have 4 complications. Non-union avascular necrosis. You are moving from the neck. Non-union head. Avascular necrosis, hip, osteoarthritis, everything, osteoporosis. So 4 complications of fracture neck of femur if you get a old case. Now if examiner asks you, supposing there was internal rotation deformity, not external rotation deformity, sir, then my diagnosis would have been a posterior dislocation of hip, flexion, adduction, internal rotation. Supposing there was a flexion, abduction, external rotation, so then my diagnosis would have been an anterior dislocation of hip. And the anterior dislocation of the hip is the only case where there is true lengthening. If none of the deformities, it is a joker. Alright? Combination of what? I don't know. So if it is a joker, still there is pain, swelling, deformity, loss of function, do a per-rectal examination, see whether the head is felt inside the pelvis, do a Morris's biotrochanteric test, and say that this is a case of central fracture dislocated hip. What to do? Long distance splint, put the patient nil-orally because she may need surgery or anesthesia, put a below D balanced skin traction. As you reach the hospital here. Then you take an X-ray of the pelvis with both hips in identical position. In X-ray of the pelvis, read it. They put the X-ray and say read it. So you say there is an X-ray of the pelvis, AP view with both hips in identical position. I say that there is a fracture neck of femur because there is a break in the Shenton's line. In anatomical classification, subcapital transcervical basal. Powers angle 60 degree, 70 degree, whatever. Gardens stage 1, 2, 3 or 4. If it is an old case, I will say whether there is non-union, avascular necrosis, osteoarthritis or osteoporosis. And after this good reading of the X-ray, they may ask you, supposing the Powell angle is less than 30, so then the muscle force and the weight of the patient will compress the fracture and the chance of union are higher. Supposing the Powell angle is above 70 degrees, so there will be shearing and the chances of union are low. Then after these classifications, you can say, I will put the patient on below D balanced skin traction, I will do a strict intake output charting, I will care for nutrition and nursing, prevent bed sore, I will investigate for anesthesia and surgery, that means medicine reference, anesthesia reference. To assess the patient, general condition of patient, I will do a hemoglobin DLC, ESR, GBT, BT, CT, blood urea, blood sugar, urine and stool. Blood idea is very important, because if the patient is not taking nutrition, she is likely to be in pre-renal uremia. Okay? Then instead of coagulation time and bleeding time which we did in olden days, you can now do an INR. Then to judge the cardiorespiratory state of the patient, I will do an EKG, echo and X-ray test PA. Then I must know the rehabilitation potential of patient. So begin with the mental, come to the vision, and then general activity or weight of the patient. Weight is very important, because obese patients respond far worse than non-obese patients. And here I will try to write comorbidity, any comorbidity. Alright, patient has had an attack of cerebrovascular stroke previously. Patient is obese. Patient has a knee osteoarthritis. Obviously the rehabilitation potential is poor. Then patient under general anesthesia, part preparation and draping done. Under 65 years, I will close, reduce and fix it by cannulated cancellous screws or dynamic extrude. Now, very important, put the patient on the fracture table. Some of you have been in the operation theatre and you have seen the reduction. And then after good traction, under image intensifier, just shake the thigh like this and pull it out. That is called as Campbell's method of close reduction. Okay? Campbell. Okay? After reduction, under image intensifier, place cannulated cancellous screws, or you open it and do a dynamic extrude. If the fracture is basal, then you need a DHS. If the fracture is subcapital, then cannulated cancellous screws would be better. Okay? Then if the fracture is irreducible, you open, reduce and fix it, but also you add a bone graft. That operation is called as osteosynthesis. Now, this bone graft is either the iliac tuberosity, जिसे TFL arise होता है ना, TFL based or quadratus femoris based bone graft. The operation is called as osteosynthesis. The alternative is that you can do a subtrochanteric valgus osteotomy, and you see how the muscle force acting like this, would start opposing the weight. So when it was straight, it was causing a shearing stress. But now, since the power angle has reduced, it will produce a compression force, and there will be much more likelihood of union of fracture. Now, if the patient is above 65 years of age, only head involved, hemi-replacement arthroplasty, head and acetabulum both involved, that means osteoarthritis, total limb replacement. Patient is poor, needs ground level activity, or has osteoporosis so that the implants would not hold. Excisional arthroplasty. Problem will be shortening Trendelenburg gait, but there will be full movement and no pain. Full movement and no pain. I have seen a coolie carrying heavy loads up the stairs of the Charbagh station with excisional arthroplasty. So excisional arthroplasty in these poor patients is not a bad one. But if you want to prevent or treat Trendelenburg gait, combine your excisional arthroplasty with a pelvic support osteotomy, where you shape the upper end of the femur with the shape of the pelvis. So there is neither abduction nor adduction nor shortening, and no Trendelenburg gait. So this combination of pelvic support osteotomy plus excisional arthroplasty is called as Milch-Bachelor operation. Right? So we have still a lot of time. But we'll take
the cannulated cancellous screw, the DHS, the hemi replacement arthroplasty, the total hip replacement, the external fixator for trochanteric fracture fixation, the PFN proximal femoral nail, and the pelvic support osteotomy. So these are the techniques that you must know.